Hi, my name is Dr. Sidra. I'm a doctor working in dermatology in the UK, and today I'll be covering some of the common types of superficial fungal skin infections we see in the context of flooding. So what I'll be covering today is just a little bit about flooding and skin disease, a bit of background about fungal skin infections, and then just an overview of the more common superficial and cutaneous fungal skin infections seen during periods of flooding. So this will include clinical signs and symptoms, important differentials, investigations, and management. And the management, for the most part, will focus on adults. So as many of you are aware, disastrous floods are becoming increasingly more frequent and more severe in recent years. Many believe this to be a direct result of climate change, including global warming. It is important to keep in mind that one of the important consequences of increasing extreme weather events is the damaging effects it can have on health and healthcare infrastructure. In particular, skin disease is commonly seen in this setting, and it's important to bear in mind dermatological manifestations that can be seen, which include traumatic injuries, communicable disease, consequences of chemical exposures and malnutrition, but also due to the reduced infrastructure, decreased access to care, and living in crowded conditions. So today I'm going to be focusing on fungal skin infections that we see in this context. And fungal skin infections, some authors do split into superficial, which includes common yeasts, cutaneous, which is essentially dermatophyte infections, otherwise known as ringworm or tinea, and subcutaneous fungal skin infections, which are the deeper, which involve the deeper structures of the skin. And my colleague, Dr. David Chandler, will be covering that shortly. So we'll be focusing on just the superficial and cutaneous. So fungal skin infections are very well reported in the context of flooding. Cutaneous infections of both typical and atypical fungi are becoming increasingly recognized after flooding, and this is due to a number of reasons. Pathogenic fungi can become displaced from their natural habitat and cause infections. Prolonged exposure to water can increase the risk of both superficial and cutaneous fungal skin infections. And it is very well reported that tinea, otherwise known as dermatophyte infections, is the most common fungal skin infection observed in flood victims. And tinea or tinea pedis, which is a dermatophyte fungal infection of the foot, is the most common type seen. It is also important to bear in mind that superficial and cutaneous fungal skin infections are also very commonly reported amongst displaced populations or people living in crowded conditions, which again we know can be a result of extreme weather events as well. So for the purpose of this talk, I'm just going to focus on a handful of the more commonly described superficial and cutaneous fungal skin infections that have been described in the context of flooding within the literature. So this is going to include pityriasis versicolor, often referred to as tinea versicolor, but tinea should really be reserved for dermatophyte or ringworm infections. And this is a yeast infection of the skin, and it often involves the upper chest and back. And then a cutaneous fungal skin infection. So this will include tinea corporis, which is an infection of body surfaces other than the feet, groin, face, scalp, hair, or beard area. Tinea cruris, which is an infection of the groin, proximal inner thighs, buttocks, and perineum. And tinea pedis, which is an infection of the foot and interdigit spaces. So pityriasis versicolor is a very common infection caused by the yeast Malassezia, and it presents as flaky, discolored patches that can appear on the chest and on the back. Clinically, these patches can be hypo or hyperpigmented, and if there is an associated inflammation, they can present as pink patches as well. Pityriasis versicolor is most frequently seen in young adults and slightly more common in men, but having said that, it can affect all ages and all genders. Pityriasis versicolor is more common in hot, humid climates. So here are some clinical images, and here you can see these these hypopigmented patches, and if you were to run your fingers over them or over the surface, you may feel some fine scale. An important differential diagnosis of pityriasis versicolor, of course, is vitiligo, which many of you may have heard of. This is an autoimmune skin condition, and the white patches or pale patches are often described as milky white, and they often have a well-demarcated border. The difference here is, of course, if you were to rub your fingers over the surface of the skin would feel of a normal texture. The borders are well demarcated, and this generally tends to be symmetrical. So do you need to do any investigations? Usually not. This is often a clinical diagnosis based on the characteristic clinical features. If there is any diagnostic doubt, or if you have tools available, useful things can be a Wood's lamp. You can shine the light over the lesions, and in pityriasis versicolor, the active patches will glow a yellowish orange glow, give you a yellowish orange glow. And an important note is that patients with vitiligo, if you were to shine the Wood's lamp light over their patches, it would enhance the white. So that's one way to differentiate them. Again, if the tools and the expertise are available, direct microscopy can be very useful of skin scrapings. And here you would use 10%, usually potassium hydroxide. And you would be looking for the classic hyphae of the yeast cells that resemble a spaghetti and meatball appearance. And we usually wouldn't expect much on culture. So in terms of treatment and management for pityriasis versicolor, so usually topical treatments do suffice. You can use selenium sulfide shampoo, but of course avoid in pregnancy or breastfeeding patients. Other commonly used topical treatments are azole-based creams or shampoos. Our go-to here is ketoconazole 2% shampoo. We would recommend patients form a lather with the shampoo and essentially apply it to all the skin from the jawline down to cover most of the trunk, and to leave it on the skin for at least 10 to 15 minutes. And they can repeat this process once or twice a week. They can do it more frequently if they can tolerate it, but it's important to warn them that it can dry out the skin. And they can continue this once monthly as a preventative measure as well, once the skin has cleared. Very occasionally, if topicals have failed or you have a patient with very extensive disease and you want to opt for an oral agent, oral itraconazole is often used, but again, avoid in pregnancy or breastfeeding patients, and we usually give a dose of 200 milligrams once daily for 7 days for adults. In this situation, oral terbinafine is not effective as it has low efficacy against yeasts. So moving on to tinea corporis and cruris, essentially begin as these itchy, circular or oval-shaped plaques or patches that can be red or hyperpigmented. They spread centrifugally, so they spread from the center out, and as they advance, they have what we call an advancing edge. So this is raised, the scale is concentrated around the edge, and it gives you this classic ring-shaped appearance, otherwise known as an annular appearance. Occasionally, the borders can become papular, so they can develop small, firm, hard bumps or spots, or pustular, so they contain small pus-containing lesions around the edge. And this is often associated with itch. And here again are some clinical images, and you can see the image on your left, you've got a pink, scaly plaque with the advancing edge, and you can see the scale concentrated around the edge and less so in the center. And then again on the right, a similar annular plaque with an advancing edge with some scale, but here you can also see some of the small little papules around the edge. And again, just some images of tinea cruris. So these are two images of the groin, and again you can see that more inflamed pink advancing edge with some small little papules. And similarly here with the image on the right, and you can probably appreciate that the scale is concentrated more towards the advancing edge as well. And that's, and just a further note about tinea cruris. So can start as asymmetrical, but can be bilateral. It usually spares the scrotum, penis, and vulva, and it can involve the perineum and the buttocks. So moving on to tinea pedis. So as we mentioned earlier, this is the most commonly described fungal skin infection in the context of flooding. It has three clinical presentations, if you like. So the first is the interdigital type, with redness and maceration, itch and pruritus of the interdigit spaces between the toes. Secondly, there is the vesicular type. This has a much more acute onset, and you get intensely itchy spots or vesicles that are more common on the instep of the foot. And then finally, the moccasin type, with a more sort of diffuse erythema and scale involving the plantar foot, but it can extend onto the medial and lateral aspects of the foot. And we'll go on to have a look at some pictures of all of these. So the first image here on the left, you can see the interdigital type with the maceration and scaling of the interdigit space and some redness. And here you've got the vesicular type with a small vesicles, probably hard to make out in this image, and papules on the instep of the foot. When talking about tinea in general, but tinea corporis, crurus, and pedis, an important differential is psoriasis. So psoriasis can also present with pink or red inflamed scaly plaques, but ways to differentiate it. So psoriasis is usually chronic, it is relapsing and remitting. It is usually symmetrical. You would look for other body site involvements like nail and scalp. And another key point is that there is scale throughout the lesion. So it's not concentrated around the edge. There is no advancing edge. You generally get scale throughout. And here, just a selection of images of patients. And these images are taken from a really excellent paper that I've actually recommended at the end in some useful resources. So this is from Rawlings et al. And this paper is a review of skin disease during extreme weather events. And so the top three images, panels A, B, and C, you can see the different presentations of tinea pedis. And then D, you can see a nice annular plaque here with the advancing edge of tinea corporis. And then panel E has got quite a severe or quite extensive presentation of tinea crurus. And although not pink or red or erythematous, this is a more sort of purpley blue color. And it's important to remember that in different skin tones, inflammation may present in different ways. It doesn't necessarily have to be that classical red color. In darker skin tones, you do see more of like a purplish bluey hue. But what you can see here clearly is that advancing edge along the lesion. And then finally, panel F is a patient with pityriasis versicolor, and you can see the fine scaling hypopigmented patches. And then the bottom two images here, G and H, are images of intertrigo. And then that final image, I, is one of chromoblastomycosis, which is a deep fungal skin infection that, as I mentioned earlier, my colleague, Dr. David Chandler, will touch on. So when it comes to tinea, again, for the vast majority of cases, diagnosis can be made clinically. You're looking for these classic clinical features. If you suspect tinea in one body site, look for other body site involvement. So if you see it on the feet, look in the groin or look on the hand. However, again, if there is any diagnostic doubt or if you have the tools and facilities available, you can use skin scrapings for direct microscopy. As we mentioned for pityriasis versicolor, you would use a potassium hydroxide, usually 10%, to look for the fungal elements. And again, if available, you can send off skin scrapings from culture as well. But having said that, if you have direct microscopy available to you immediately, you may not necessarily need to send off samples for culture. So again, we mentioned the probably most useful and more commonly used tools for diagnoses would be direct microscopy, fungal culture if available, and very occasionally you may biopsy a lesion and use special stains, but very rarely for the superficial fungal skin infections. So now moving on finally to management. So general measures are always really important. So ensure that your patients understand where possible to wear loose fitted clothing, wash affected areas daily, pat dry, especially the skin folds. Make sure these areas are clean and dry. Avoid scratching of the skin because this may spread infection. And again, where possible, it's important to advise patients not to share towels, clothes, and wash bedding regularly where possible because fomites can spread this way. For mild localized disease, we usually would recommend a topical antifungal. So in adults, topical terbinafine 1%, but you can also use topical clotrimazole or miconazole, depending on what is available. The azoles are licensed for both adults and children, so that's a benefit of them. Very occasionally, if disease is very severe or recalcitrant and not responding to multiple courses of topicals, or you have very extensive body surface area involvement, you may opt to treat with oral antifungals. So for adults, we can prescribe oral terbinafine, 250 milligrams once daily. And so for tinea corporis and crurus, that's usually a course of 2 to 4 weeks. And again, avoiding patients with known hepatic or renal failure, and you want to avoid in pregnant and breastfeeding patients. For an alternative would be itraconazole, and this may be the preferred option. I know there are concerns about terbinafine resistance, particularly in Pakistan, India, and Bangladesh, and itraconazole may be preferable to use. So if that's the case, you can prescribe 100 milligrams once daily for 15 days, or alternatively 200 milligrams once daily for 7 days for your adult patients. And you want to avoid in patients with a known diagnosis of porphyria, hepatic or renal failure, and again in pregnant or breastfeeding women. Tinea pedis, pretty similar in that you want to apply good general measures first, so good regular cleaning of the feet, washing and drying, particularly between the toes, avoid occlusive footwear. In mild disease, topical antifungals are fairly effective, and our go-to would be topical terbinafine. Again, for more severe disease or disease that has previously failed topical therapies, you may want to opt for oral antifungals. And if that's the case, for your adults, the dose would be 250 milligrams, but for slightly longer, so for 2 to 6 weeks. And again, similar avoidance advice. And then again, if you don't have terbinafine or you want to avoid terbinafine, oral itraconazole can also be used. And the doses for adults, 100 milligrams once daily for 30 days, or 200 milligrams twice daily for 7 days, and similar avoidance advice. An additional sort of note for the patients with tinea pedis, particularly say with the more hyperkeratotic skin, particularly in the moccasin type, would be consider adding in what we call a keratolytic agent, so an agent to break down the thick skin, the keratin, and that could be a urea-based cream or a topical salicylic acid. And then finally, I just wanted to put up some useful resources, particularly Dermnet NZ, which is very helpful, but also the WHO has a Skin NTD app, which is more useful for the deep fungal skin infections, and it has tools for helping you make the diagnosis clinically, lots of clinical images and some treatment pathways. And the paper that I had mentioned from Rolling and Zettel, which is the dermatological manifestations of extreme weather events. It's a really good paper. I highly recommend reading it. Thank you.